This is the third part, compartment syndrome, pelvic fractures. So what's the definition of compartment syndrome? Compartment syndrome means increase in the intracompartmental pressure in the leg or any part of the body that leads to pressure over the arterioles and the blood supply that can lead to ischemia. طبعا, what are the risk factors are very common, mostly fractures, extravasation of fluids in the compartment, bleeding. When this happens, the pressure in the compartment will be elevated, and that will compress the blood supply and the capillary, the arterioles, and that will lead to damage and swelling in the tissues. And when the pressure increases with time, the damage will increase and there will be lack of oxygenation, and this cycle will continue. So how to diagnose compartment syndrome? You have to understand what's the normal intracompartmental pressure and what's abnormal. So if you have an absolute intracompartmental pressure of 30 or more, that's an indication that the patient might be having compartment syndrome. And also you can measure the difference between the diastolic pressure and the intracompartmental pressure. And if you measure the difference and it's less than 30, that means that the patient is having, compartment syndrome, or the blood supply to the limb is jeopardized. So let's say you measure the intracompartmental pressure and it's 20 or 25, but the diastolic pressure is very low. Let's say it's 55 or 50. Then you have what they call the delta. You have a difference of less than 30, so that means the blood supply to the limb is not sufficient. Risk factors: trauma, injection, as we mentioned, bleeding, prolonged vascular occlusion, and then reperfusion, burns, snake bite, intraosseous fluid replacement, eye fluid extravasation, tight bandage, and also post-surgery this can happen. Also, there are some general risk factors like head injury, decreased consciousness, because that will lead to missing the diagnosis, and also hypotension, as we mentioned, can sometimes affect the blood supply delivered to the limb. Diagnosis usually is clinical. So early diagnosis with pain, usually pain increase with stretching of the involved compartment. They call pain out of proportion. Presence of risk factors also is important. High index of suspicion in these cases. Measurement of compartment pressure is helpful sometimes, but only in patients who are unconscious. In a conscious patient, you don't need to measure the compartment. Late signs: paresthesia, paralysis, pale skin, and in very, very extreme cases, you might have a pulseless limb, but this is a really late presentation. So again, beside these signs, you check for a tight heart compartment, tenderness in the compartment. As you mentioned, measurement is only indicated if the patient is having altered conscious status. And in some cases, if you have, a borderline presentation, you can confirm with the measurement. Management is very important to maintain normal blood pressure, remove any constrictive bandage, keep limp at heart level, give diuresis to avoid kidney tubular injury if this is late. Then you have to do an emergent surgical decompression, fasciotomy. It's not only urgent, it's actually emergent. It's more, it's more emergent than what you think. So fasciotomy, you release the compartment fascia, you allow swelling of the muscles to expand in volume. That will decrease the compartment pressure. This will avoid further damage. Does not reverse already occurred damage, however, it helps in decompressing the intracompartmental pressure. And this should be done, as we mentioned, as soon as you diagnose the patient with compartment syndrome. So when do you do compartment syndrome? So you should do this as long as there is still viable tissues. Should not be done if there is no expected viable tissues, otherwise infection is very likely. Once you do the fasciotomy, you should debride all the necrotic tissues. Second and third look surgeries are often required to make sure that the patient is not developing any necrotic tissues and infection. Closure of skin is usually achieved after swelling has subsided, and most of the time you need to apply a skin graft, just like the picture here. So this is fasciotomy closed with a skin graft, because sometimes it's not easy to close down the skin. And you don't want to wait for a long time till the skin is closed. And at the same time, if you leave it for a long time, the skin will retract and it will be very difficult to close it back. So usually a fasciotomy is a prophylactic procedure. Does not reverse injury to permanently damaged tissues. So better to have very low threshold to do it and do it early. So complications of compartment syndrome, you would have myonecrosis. This myonecrosis will go to the circulation and also through the renal system and cause kidney tubular damage. Loss of function of the involved compartment will cause flexion contractures, paralysis, loss of sensation. So this is very important to keep in mind. If you have an anterior compartment, usually the common functional deficit is drop foot. The posterior compartment is clawing of the toes, loss of sensation in the sole. In the forearm, always remember the famous Volkmann contractures after a supracondylar fracture, especially in pediatrics. Okay, the second part is about acute joint dislocation. And as you all know, that acute joint dislocation is an orthopedic emergency. You have to understand what's making these joints stable, to understand when do they dislocate and when can you call them unstable. So stability mainly comes from the bone. So there's bony stability based on the shape of the joint. Ball and socket are more stable than round on flat. So ball and socket is the hip, round on flat is the shoulder. Soft tissue stabilizers, there's two kinds. There's dynamic stabilizers, there's static stabilizers. So dynamic stabilizers like the tendons, muscles, and static stabilizers like ligaments, meniscus, and labrum. There is usually complex synergy leading to functional stability of the joint. So not only the muscle, not only the bone, or only the muscle, or only the ligaments, should be a synergy effect of all of them. It takes high energy to dislocate a joint with body stability with bony stability than a joint with mainly soft tissue stability. And remember the hip compared to the shoulder. The shoulder is commonly dislocated while the hip is rarely dislocated and requires a very high energy. Connective tissue disorders may lead to increased joint instability due to abnormal soft tissue stabilizers. Dislocation of a major joint should lead to considering other injuries like fractures or other joint dislocations. So who's at risk? Major trauma victims, athletes and sport enthusiasts, connective tissue disease patients. And usually when you describe a dislocated joint, you should describe the distal part in relation to the proximal part. Anterior shoulder dislocation is anterior displacement of the humeral head relative to the glenoid. Posterior hip dislocation is posterior displacement of the femoral head relative to the acetabulum. So what's the difference between dislocation and subluxation?
subluxation تيجي قبل الديسلوكيشن يعني زي dislocation بسيط أو كذا.
Incomplete.
أو incomplete.
Loss of contact between both ends of the joint. While dislocation is complete or total loss of contact between the articular surfaces of the joint. And also there is acute and chronic. Acute happens immediately. Chronic happened over a long time and there is some changes. See these pictures? So this is chronic subluxation of the joint. You can see some remodeling and change in the appearance of the proximal tibia. So diagnosis, you should take good history, make sure there is no major trauma. Pain and inability to use a limb also is an indication of a dislocated joint. Deformity, shortening, malalignment, malrotation of the limb also can indicate dislocation. Always check other injuries, always check distal neurovascular examination, and also don't forget compartment syndrome. Obtain x-rays should be done urgently without delay if dislocation is suspected. 2 perpendicular views of the involved joint. Occasionally special views are required, such as auxiliary view for shoulder dislocation, x-ray to a joint above and joint below. Management principles, so must rule out other injuries as we mentioned, should give pain medications, urgent reduction, check stability of the joint and check the safe zone by checking range of motion. Check the neurovascular status after reduction. Obtain x-rays. You have to protect the joint by immobilizing it if needed, and then start rehabilitation and follow up for late complications. Reduction, as we mentioned in one of the seminars, monitor vitals, IV analgesia, IV sedation, gradual traction to distract the joint, and there should be some counter traction, reversal of the mechanism of injury or the mechanism of dislocation. Once you hear a pop or a clunk, it means the joint is reduced. Check range of motion to confirm that the joint is in place. Always don't forget distal neurovascular examination. You have to check it before and after. Sometimes after reduction, you lose the neurovascular pulse and nerve function, so you have to be aware of this. If you give a patient some sedation, you have to observe the patient till the patient is awake. And also don't forget to stabilize the joint and get X-rays. There are two examples of hip dislocation and shoulder dislocation. Always remember to give sufficient muscle relaxant. And in some cases where you have difficulty reducing the joint, consider having some soft tissue interposed. Special considerations: a fracture dislocation is usually reduced in an open fashion in the operating room because usually it's difficult to move the limb. Since it's fractured, must confirm concentric reduction on the X-ray, otherwise an open reduction should be performed. What are the early complications of HO? What are the early complications of joint dislocation? Heterotrophic ossification, which is ossification of the hematoma around the injury. This is more or less considered a late complication, but early complications mainly are neurovascular injury, compartment syndrome, ossichondral fracture, and then the late we'll call heterotrophic ossification, one of them stiffness, chronic instability, avascular necrosis, and also arthritis. Some special considerations. So in the hip joint, posterior dislocation is the commonest. Major trauma with hip flexion, we call it dashboard injury. Sciatic nerve is at risk, high incidence of late avascular necrosis. And as we know, this is an orthopedic emergency. Shoulder anteriorly is the most common. Seizure, electrical shock, alcohol intake make it more prone for posterior dislocation. May have chronic instability, especially in young patients. Can result in axillary nerve injury. In the knee, you should have 3 or more ligaments involved. Usually, very high energy is needed to make this happen. Popliteal artery is usually at risk because it's tethered proximally and distally to the knee. Very serious emergency needs accurate vascular assessment. And also need to check the peroneal nerve. And also rule out compartment syndrome. There's a picture of a CT angio which shows that the blood supply is stopping at the behind of the knee. That means that there is some vascular injury and occlusion. Pelvic trauma. It's very important to understand the anatomy of the pelvis. Pelvis is composed of 3 bones, 2 iliac bones and 1 sacrum. Iliac bones are connected to the sacrum posteriorly by strong ligaments. The strongest is the posterior sacroiliac ligament. It's also very important to understand the vascular tree within the pelvis, because when you have a pelvic injury, you have high risk of bleeding from these vessels or from the bone itself. And also it's very important to understand the direction of instability. So you can have instability in the rotation or instability in a vertical direction. Why is a pelvic fracture considered an emergency? When you have bleeding inside the pelvis, if the bleeding is venous or from the bone ends, you will have a tamponade effect after accumulating certain amount of blood. But if you have an unstable pelvic ring injury, the volume of the pelvis will increase, and then the amount of blood needed to reach the tamponade is really high. So that's why you need to identify pelvic fractures, reduce them, and stabilize them as soon as possible, just to decrease the volume and decrease the need of, or decrease the amount of blood needed to achieve the tamponade. In history, you have to ask about the energy. Mechanism of energy is very important. Anterior versus lateral versus axial force, pelvic skin contusion, bruising, short extremity, careful neurological assessment. And as we mentioned, once you do the ATLS protocol, which is A, B, C, D, E, you have to examine the pelvis, and if there is any suspicion of pelvic injury, you should put a binder. The binder is folded sheet wrapped around the pelvis, centered on the greater trochanter, and then tightened just to make sure that the pelvis is closed down and stable. Clinical diagnosis is very important. Rectal exam, check for bone fragments, high riding prostate, bleeding, blood at the meatus, labial or scrotal ecchymosis, and check for the vaginal examination also for the same thing. Rule out any bone spikes. So management: stabilize the pelvis first with a binder. If vertically unstable, apply traction. IV resuscitation is also very important. Look for other injuries and check for the response. If you resuscitate the patient and there is only partial response, this might require angiography for embolization of active bleeders, especially arterial bleeding. This might also this patient might also require pelvic external fixator or clamp, which is similar to an external fixator, but it can be applied in the emergency room, just to make sure that the pelvic volume is reduced and the pelvis is stable. Early diagnosis of pelvic fracture in polytrauma patients is very important, can save their lives. Remember, aggressive resuscitation is key, and then control any active bleeding, especially in the pelvis and the abdomen. Thank you very much. Do you have any questions regarding this? متأكدين هذه ما أعطاكم إياها دكتور إبراهيم الأسبوع الماضي ها؟ ممتاز.